Hi, my name is Will Courtney, and welcome to Healthy Living, a production of the Lowell Health Department and its many partners. One of those partners is Circle Health and Lowell General Hospital, and today we have Dr. Anna Gunturi and Dr. Lerna Ozcan from Lowell General Hospital's Cancer Center. Thank you guys for coming.
Thank you for having us.
We're talking today about breast cancer awareness. For October, it's Breast Cancer Awareness Month. So you guys have come down to talk to us a little bit about the importance of screening and the amazing treatment we have here in our community. It's not just another cancer center, and we say that all the time. Maybe we could start with just talking about how important screening is. We have part of what we try to do is make care convenient, and we have several screening sites around the community. You can find those at our website. We try to make it convenient. Why is it important to not put off a breast screening and keep up with it year to year?
Yeah, it's extremely important. In cancer in general, and especially with breast cancer, detecting cancer at an early stage makes literally a difference between life and death, in the sense that, when we detect cancers in the beginning, in early stages, there's a chance for cure. In fact, a very high chance for cure. Breast cancer is one of the highly curable cancers that we have out here, but only if it's detected early. And so mammograms give us that power to be able to detect the slightest abnormalities early on so that we can diagnose the patients appropriately and give them the treatment that they need.
And that a year can make all the difference. If you say, well, I'll just get mine next year, I was okay last year, I'll skip a year.
Yeah, absolutely. I mean, the guidelines are based on clear data that shows that an annual mammogram is essential. These breast cancers can grow fairly fast, and if you delay it even by a year or two, and we have cases like this all the time where the patient, unfortunately did neglect it, and by the time we find it, it's at a later stage and harder to cure. So being punctual, getting a mammogram every year, starting at age 40, is what we recommend.
And I would like to add that the goal of a screening test is always to detect a cancer before it may cause any symptoms. So we don't want women to present when it's palpable to them or when it caused any other signs of spread. So the goal of a screening test is really to detect it before it causes any symptoms, and that is the major goal of a screening mammogram. Ideally, every year is recommended starting at the age of 40.
And that's a good point. I should just give you a proper introduction. Dr. Gunturi is Medical Director, Associate Medical Director of Cancer Care Associates, and she's a medical oncologist.
Yeah.
Dr. Ozcan is the Medical Director of our Breast Center of Excellence and a fellowship-trained breast surgeon. There's been some talk, or some gray area maybe for some people about starting at 40, and there may be some mixed messages over the last couple of years. Why do we say start at 40?
There is different societies that have different guidelines and recommendations. We go by societies that recommend starting at the age of 40 every year. The reason for that is because the risk of developing a cancer increases significantly after the age of 40. And therefore, we will catch more women who get diagnosed with a breast cancer at an earlier stage who are younger. Therefore, we go by, for example, the National Cancer Comprehensive Network guidelines, the NCCN guidelines, who recommend screening mammograms starting at the age of 40 and then annually thereafter. It is important to say that women under the age of 40, however, who do have complaints should bring this up to their provider and can have testing done as well. Those are different testings. They're not considered screening, but generally speaking, for the population at average risk, screening at the age of 40 and annually thereafter is recommended.
And then if you have a lot of breast cancer in your family, you should speak with your physician about maybe being at high risk. And could that change if somebody has a lot of breast cancer in their family? Would they potentially go before 40?
Absolutely, yeah. So there are guidelines specific to women who are deemed to be high risk. In fact, here at Lowell General, about a year ago, we started calculating a woman's risk for breast cancer over her lifetime, and including that risk result in their screening mammogram report. So now a lot of women out there who may not have known that they're high risk are getting that information. The primary care doctors are given this information. And now we have a high risk clinic within the cancer center where we offer these kinds of consultations for these women, not women who've been diagnosed with breast cancer, but those who have been deemed to be at high risk because of the density of their breasts or their family history and various factors. And so it is important to have that conversation because there are things that can change. We can do various different types of screening tests to try to detect cancer early on for these patients. We also offer them something called chemoprevention, which is basically hormone therapy to try to reduce their risk for breast cancer. So there's a lot, there's a lot that goes into it. Genetic testing, obviously, is also part of it. So it's critical that patients pay attention to this. And now that we are able to offer this new information and service to our community, I would, encourage everyone to talk to their doctors about it.
If someone thinks says, well, geez, maybe I am high risk, and now I have this service here locally, and I want to find out, what is the process of finding out? Do you start with your primary care physician? Do you call the high risk clinic directly? You typically would start with your PCP and have them refer you, right?
Ideally, you start talking to your primary care provider about it, and in fact, a lot of our patients get referred to either of us or directly to the high-risk clinic that have had prior discussions with their primary care providers. Because of the new system we have developed here at Lowell General Hospital, where women get notified about their risk on their mammogram report, they are also given the number directly to call our high-risk program and can be given an appointment at their convenience. We do encourage to call their primary care provider. They can call our offices as well or the high-risk program directly.
Okay, great. So a mammogram might be scary for somebody, the idea of, especially if they're at high risk, and the fear of finding an abnormality. What is it? An abnormality isn't necessarily cancer, right? What happens when the radiologist discovers an abnormality?
And a mammogram, again, the goal of a mammogram is to detect any abnormality at an early stage. So even if a woman gets diagnosed and gets called back for mammogram, most of these findings turn out to be normal breast tissue and do not require any further workup, such as a biopsy. So women who do have a mammogram and do get called back should not be afraid, because most of those findings turn out to be normal or what we call benign. If an abnormality is found, that can be anything that can be just watched, and most of these women will be followed. If it is suspicious enough to warrant a biopsy, then our radiology team takes care of those patients, proceeds with a biopsy, and then determines the next step of treatment. Again, because they're undergoing a screening mammogram, even if an abnormality is found, most of these patients, if it turns out to be a cancer, will be diagnosed with a very early stage breast cancer that is not only treatable but curable for the majority of patients.
So that person who is identified, they'll be referred to one of you. What is the next step once that scary sort of, who gives the news, and how is that handled?
So we actually have an excellent breast navigation system. So we have breast navigators within the radiology department. Their sole job is to deliver this kind of news initially to the patient, also to inform the primary care doctor. And then we present the case in a multidisciplinary conference. So once a week, we all get together, the radiologists, pathologists, surgeons, oncologists, radiation doctors, a whole group. We also have clinical research team present to see if any patients are eligible for that, social work. I mean, it's a truly multidisciplinary effort. And every new diagnosis is discussed there. And we basically come up with a plan, what comes next. I would say majority of the patients, since they are being diagnosed at an early stage, and because of the particular type of breast cancers that are most common, they do need to see a surgeon first. And so they get booked with, scheduled with one of the surgeons and have a discussion about that. Oftentimes, the first step is surgery, so they go forward with lumpectomy, or in some cases mastectomy, and then the patient is directed to the cancer center where they meet one of the oncologists to then discuss what additional treatments might be necessary for the patient. So everything is, smooth and taken care of, and there's a navigator helping the patient along the entire journey.
And one thing worth pointing out is that this isn't typical of every cancer center, this multidisciplinary approach, right? This is something that people would say, well, I want to go to Boston. I want to, because that's where I'm going to get the best care, because the Boston brand is legitimately, they're great hospitals. But you have all trained alongside these same people, and we're using those same tools, those same processes. Is that accurate?
That is absolutely accurate. We have a multidisciplinary approach to treating our patients diagnosed with breast cancer, similar to other breast centers in the country and in the state, including Boston. It is important to note that we do provide this high standard quality of care to our patients in the community, close to home, close to their primary care physicians, and close to their families. It is a long journey, often including surgery, including radiation, sometimes requiring chemotherapy, and it's important that you can have this standard of care patient-centered, close to home. And so it is important to know that we are away from any major center or any major city, and we have everything a patient needs right here in Lowell for them.
And for someone who's going through that in their family, to be able to go down the street versus going far away is part of their treatment in a sense, right? It
makes a big difference. I mean, it's a stressful time, right? I mean, being diagnosed with cancer is probably the most difficult period of our patients' lives, and any extra stress, whether it's traffic, parking, just being far away from your support system, can be difficult to navigate. And so it gives us, immense pride to be able to deliver excellent care, equivalent to any other major center right here in Lowell.
And worth mentioning too, we even just opened up a pharmacy on campus. We really are trying to, when we say complete connected care with Circle Health, we really are trying to connect everything to make it as easy as possible on patients. So if somebody gets to the point where they have to come see you, Dr. Hoskan, they've got a lump, they've got an abnormality that's been diagnosed. Things have changed quite a bit, even in the last 5 or 10 years, right, of how you would then approach that abnormality. What are some of your options now that have kind of changed, and what is your approach, modern approach?
Absolutely. So a lot of the reasons for being able to do less aggressive surgery is because of the role of screening mammograms, being able to detect breast cancers at an earlier stage when they're smaller, when they haven't grown to a massive size, allows me to do less aggressive surgery. In the past, when women were diagnosed with breast cancers, having not had the opportunity to undergo screening mammograms, they were often diagnosed at later stages, required more aggressive surgery such as radical mastectomies, which means they required removal of their entire breast, all the skin, the nipple, and all of their lymph nodes, and in radical mastectomies, sometimes even the underlying chest wall muscle. Over the years, because of being able to detect cancers earlier, they were able to spare removing, for example, the muscle. And as the years have passed and women were diagnosed at earlier stages, we're now able to offer women lumpectomy or breast conservation. That is removing the tumor, removing normal surrounding breast tissue, but allowing women to keep their natural breast tissue. And that has really impacted a woman's quality of life. We do also offer, treat women with lymph node surgery, that is lymph nodes under the armpit, because that is where breast cancer spreads to the first. And similar in the past, when women presented at later stages, those lymph nodes were often involved. Now most women, when they present with early stage breast cancer, do not have lymph node involvement. And instead of removing all the lymph nodes under the armpit, which causes significant morbidity, swelling of the arm called lymphedema, muscle issues, nerve problems, motility issues, we can now offer them a technique called sentinel lymph node biopsy, where you only remove the lymph nodes that would drain the tumor bed. And the risk of complications is far less with that. And it is truly satisfying to be able to offer this to women nowadays.
And it leads to faster recovery times, and is just as safe, and the quality of your survival rate and whatnot, your recurrence rate are just as good as they used to be.
Just as good.
Yeah.
A lot of women do come and see me as their first stop in their care, and they have the idea of a mastectomy. Just remove the entire breast. I never want to deal with this again, and I want to live. And because of the advances in treatment, not just surgical treatment, earlier detection, but also the advances in radiation and systemic treatment options that Dr. Gunturi and her team provide, we're able to offer women less aggressive surgery with the same exact outcome. Women with breast cancer who are candidates for breast conservation, so preserving their breast, live as long as women who undergo more aggressive surgery. And that is because of the advances we've made in this in the breast cancer treatment.
We've heard of celebrities who have had trying to prevent breast cancer by a proactive mastectomy. Is that something that is still something maybe somebody high risk would consider?
Absolutely. Those are very different patients. Those are considered high risk patients. Most cancers that get diagnosed now are not related because of a DNA problem or a genetic mutation. Only 5 to 10% of women have a genetic mutation, just like the celebrity you mentioned, Angelina Jolie, had a major impact on women's decision making when she first underwent prophylactic mastectomies. That being said, the majority of women who get diagnosed with breast cancer will not have a high-risk genetic mutation, and therefore can be safely treated with lumpectomy and lymph node biopsy. Women who have a genetic mutation, strong family history, who are considered to be at a higher risk of developing a recurrent cancer, and who are at high risk of developing a cancer in the other breast, do get offered the option of bilateral mastectomies, that is removing the breast of the cancer side and doing a prophylactic mastectomy on the other side to prevent a cancer in the future. That is for women who are considered high risk. We don't recommend this for women who are at average risk.
And that's a small percentage of the people.
Exactly.
So once the surgery is done, this is not the end of their journey, of course. They often are referred to you, is that right?
Yeah, usually I end up being the second stop. So, actually breast cancer can be divided into 3 different types of breast cancers. And that's based on certain proteins that we look for on the tumor cells under the microscope. And so depending on which type it is, we may think that the cancer is a little bit more aggressive type. And in those specific situations, sometimes the patient needs some additional treatments before the surgery. And so sometimes in those circumstances, I end up seeing the patient first, offering them chemotherapy. They go through, that course and then go back to the surgeon for the surgery. But for majority of cases, it is in fact surgery first, then they come to us. And based on the various factors, depending on how big the tumor is, what type of breast cancer it is, whether it has spread to the lymph nodes or not, so various different factors, we then determine what additional treatments would be beneficial. And the key thing to remember is that, yes, the tumor that we know of has been removed by the excellent surgery that has been provided, but there is a chance of recurrence, right? So what we're trying to do is, what additional treatments can we give you now to give you the best chances for this cancer to never come back? That's the goal. And so in some cases, we do need to do chemotherapy, because we worry more that the cancer might be coming back. In some cases, if the risk of recurrence is low, then we can skip the chemotherapy. Radiation is another important part of breast cancer treatment these days, particularly after lumpectomies. radiation is pretty standard. In some cases, even after a mastectomy, we have to consider the radiation treatment. And then finally, there's something called hormone therapy. This is basically a medication. It's a pill that the patient takes once a day for 5 years. Now there's some evidence that up to 10 years might be even more beneficial. And this is particularly for patients who have a particular type of breast cancer that is called hormone receptor positive. So what that means is that these are patients who have breast cancers that are feeding off the estrogen in their bodies as nutrients to grow. And so by giving them this hormone therapy that blocks it, we're able to prevent further growth in the future. So surgery is obviously a very important part of treatment for the early stage breast cancers that we're diagnosing these days. But that's not the end of it. There is a discussion about potential chemo, radiation, and hormone therapy.
And you're good at those patients that have already, and now once they've had cancer, you're going to be watching them more closely pretty much for most of their life, right?
Absolutely. So once they get through the active treatment part of it, then they go into surveillance, is what we call it. Basically, they're coming to the surgeon's office, the oncology clinic as well, periodically every 6 months, and then after a few years, maybe once a year. But yeah, we continue to watch them because breast cancer, the recurrence risk is always there. It gets smaller and smaller as time goes on, but particularly with certain types of breast cancers, they've been it's been shown that they can recur even 10 to 15 years later. So
if it does come back, you want to catch that right away.
Again, early detection, so that we can sit down and again, as a multidisciplinary team, figure out, how are we going to tackle this.
And you really develop a relationship with these patients, right, over time. I mean, you see these folks and they get comfortable with you and they put their trust in you. And do you find that, I mean, obviously it's difficult for everybody, every cancer is unique, but the emotional piece of that, what is that like for these patients often?
Yeah, I think the breast cancer population is unique, right? And I think, I can relate to them so much because I'm also a woman, and I started having to do mammograms myself, and so I totally understand what they're going through. Oftentimes with young families, older women who are mothers and grandmothers, and it's definitely close to my heart. Being a woman myself, and can relate to the emotions that they're going through.
Sure. Is that similar for you?
Yeah, definitely. I think the importance of being a surgeon is always a technical one that one may think of. So removing the cancer technically and getting rid of it is a very satisfying process. But what really strives me is the relationship we built with our patient throughout the years. And that helps them emotionally to get through these difficult times because they come back to very familiar faces and they come back to the same team that takes care of them. And so a lot of this support is not just the true treatment of the cancer, but everything that goes around it. And it requires treatment of the family sometimes too. They come to the visits and they become a major component of the support system. And so over the years, as you build the relationship, that support group within the treating team becomes really essential.
And that speaks to the care we give. It doesn't obviously stop at just the clinical side. But while we're talking about sort of treatments and things, I wanted to talk about quickly the clinical research that we do, and that's also something that's unique to a community cancer care center. How does that sort of work into treatment? Are we using some of these clinical trials, or some of these folks in the breast treatment that they're going through these, right?
Absolutely. We have a very robust clinical trial team here in Lowell General, and you're absolutely right, that's very unique for a community hospital. And most of the trials that we do have to offer is for breast cancer, actually. And so majority of our enrollment comes from our breast cancer patients, so very proud to be offering that. Whether it's a trial that's looking at whether an additional agent to the chemotherapy regimen would be beneficial or not. We have a trial that's looking at whether in a certain setting an additional radiation area would be beneficial or not. Can we omit radiation or not? So there are all these clinical questions that are being asked, and it's very satisfying to be able to participate in this kind of research, which may be the setting stone for the future standard of care that we may be providing to our patients. So it's very unique to do that. And just to go back to the breast cancer care, I just wanted to mention that we also have something called a survivorship clinic here in Lowell General within our breast center. Again, a new program that we have to offer. So for patients who have gone through their active treatment and are on surveillance, like Lerna was mentioning, it's more than just a mammogram and a breast exam, right? So we're giving them support through support groups, education about healthy lifestyles. We now started some cooking classes to teach our patients how to, make healthy foods. We have a fitness class that they can sign up for, all at free of cost to the patients, which is amazing. And so the list goes on. But again, to go back to the fact that Lowell General is unique in that not only are we delivering excellent care medically, but also being able to give all this additional support to our patients so that they can continue to live healthy for the rest of their lives.
These survivorship programs, I know we used integrative therapies, and Mill City Grows is the one that comes and does the cooking class. I think that was just last week.
That's right.
It was sold out.
Was that right? And even things like the cool caps that help women with their hair. You're always trying to think of different things, because it isn't just this isn't just having surgery and getting chemotherapy and radiation. This is an emotional piece. And why is that extra piece important for cancer care? The integrative therapies, the support groups, and all of that. Because
cancer diagnosis especially is an emotional one, and I think it really affects people in a very deep way, and their family members. It's scary. It's very scary. That cancer means you could die from this, right? And so with that comes not just your ability to come in for your surgery or for your radiation, but also all the emotional, consequences that come from it. And so I think as a treating physician, it's our responsibility, not only, like Lerna was saying, not only to deliver the actual surgical skill or the chemotherapy regimen that I decide, but to be there as a human and to comfort them and be compassionate and help them through this journey, whether it's through these integrative therapies, whether it's social work, therapy, just a lending hand, or help with the transportation. I mean, the amount of good work that our Team Walk money goes to, it's just amazing that all the troubles that our patients are going through, behind the scene, and what Lowell General is able to do to help them with that, So it's definitely unique and something that we take a lot of pride in.
Absolutely. And the support groups especially, because they are really led by our social work team, but they're led by our patients. They share their experiences with other patients, and it improves not only their own quality of life, but also our patients' quality of life. And we often learn from our patients themselves, and how important it is to educate yourself and to keep educating others about maybe something that you did after surgery or during chemotherapy that helped you through the difficult programs and the difficult treatments. Then once that active treating phase is gone, a lot of women and families are somewhere lost. Now what? Do I just go for my mammogram every year? But what happens in between? And so the support group, the survivorship program we have, the social work program we have, really supports them in those difficult emotional phases in between the treatments.
We have social workers inside our cancer center. We're almost out of time. I want to tell the community how lucky they are to have the two of you, that I see your patients and how they react to you. They run up and give you a hug every time I've seen them. And so our community can trust the care that they're getting locally. Thank you so much for coming. We will do this again. I knew this would go quickly. Thank you everyone for tuning in to the show, and we will see you again soon. Thank you.